She won most talkative in high school, and she has been running her mouth ever since. Welcome to the Lisa Fisher Said podcast with your host, Lisa Fisher.
Okay, I've got a new best friend. Cassie, you're my new best friend because you do love the thyroid and you do love talking about menopause and methylation and all the things. But here's my one beef with you. You're an endocrinologist, and I say I don't like your kind, but I like you because most endocrinologists are the accountants of the medical world. They look at teeny tiny numbers on a piece of paper and they say, oh, your TSH, it's 3.1. You're fine. But I don't think you have that feeling in philosophy, do you?
I don't. No, you're right. I don't like many of my kind as well. So
See?
I would agree with you. We're not all created equal. I like to think of myself as the unicorn endocrinologist. So, yeah.
So what drew you to endocrinology? Because that's metabolism, that's your ovaries, that's your thyroid, your endocrine system. So what drew you to that?
Yeah, that's a good question. So I struggled with an autoimmune condition too in medical school. So I had Hashimoto's and Graves. So that's
Represent. Wait,
kind
you
of
had
what started
Hashis
it.
and Graves?
Well, I had Graves first,
And
and
it
then
swung
after,
the other way?
so I was treated with methimazole, and
Wow.
they told me I needed to have radioactive iodine and all these things, and I didn't want to do it. And so then I ended up going into remission, and then after I went into remission, I ended up with Hashimoto's. So that's kind of where it sort of started. But the real reason, honestly, I went into endocrinology, Lisa, is because I did internal medicine, right, for a year. So
Oh,
I
yeah.
got out of residency and I was practicing internal medicine. But my patients weren't really getting better, right? So I would
Right.
see people and I would put them on all this medicine. And it was like I spent the last, 12, 14 years of my life dedicated to this field of medicine to make people feel better. And I was practicing and nobody was getting better. And so I just had all these questions nobody could answer. And so I thought, well, endocrinology seems like probably the best way to learn all that, right? So that's kind of how I ended up there, to be honest with you. Unfortunately, though, in fellowship, they don't teach you much more in endocrinology fellowship than they do in medical school. So I still had a lot of questions in fellowship. But the good thing was at least I knew enough to be dangerous. And so I just started kind of learning some stuff on my own. So yeah.
Did you, what happened to your Hashis after? So, because the pendulum can swing, from what I
Hmm.
understand, that an autoimmune disease means something's on fire, right? And your fire was
Right.
here with the
Yeah.
Graves because your antibodies were whatever for Graves, and then they swung in the other direction to Hashimoto's. What do you think? What did you do to reverse it, and where are you now with? Because Graves is a serious illness. Not to say Hashis
Hmm.
isn't, because Hashimoto's can be debilitating, but Graves obviously can be a concern for cardiovascular system.
Right. Yeah, and thankfully I didn't have terrible grapes, but I think a lot of mine was induced from my lifestyle at the time, right? So I was in medical school. I might have been in
Absolutely.
residency at that point, but yeah, I mean, I wasn't sleeping very much. I wasn't eating well. I was, doing all the terrible things you do. And so I was just trying to survive. And so I got mine to go into remission with methimazole. And thankfully I didn't do radioactive iodine like, they
Yeah.
thought I should do. And so mine kind of went into remission after I think my stress was a little bit better and I realized like, hey, I need to take a little bit better care of myself. And so it went into remission and then I finished med school and then I started practicing. But then when I went back to fellowship, after I got out of fellowship, my life was kind of crazy again. And so it swung the other way and I ended up with Hashimoto's. And I think I probably had Hashimoto's longer than I realized too, because I was having some other issues, like fertility issues, some other things, but
Yeah.
nobody really looked at that.
Right.
So whenever I finally realized I did have Hashimoto's, then what I started doing was asking questions, asking endocrinologist questions that they couldn't really answer. And so I was just very frustrated. And so then I started kind of doing my own thing, right? My own research,
Yeah.
listening to people who talk about thyroid, and then I found BioT, which I don't know if you know
Yeah.
about BioT, but
I'm
so,
getting one tomorrow, girl.
okay,
Get my
perfect.
pellet.
Yep. So I found BioT. And so then that gave me a lot of answers. And then through BioT, I found a doctor that I see in Dallas. Sorry, I have this bug flying around. I found this doctor in Dallas that helped me a lot. That's more of a functional medicine type doctor and helped give me some of the answers that I needed. And so helped me reverse my Hashimoto. So I'm happy to say that I have a normal TPO antibody. I'm not on any thyroid medication right now.
Not
And I
at all.
probably feel the best I've ever felt in my life at the ripe age of 37. I don't busiest I've ever been,
Did you
but I feel the
birth
best.
something in the meantime?
I haven't, no.
That's the issue with the endocrine system and Hashimoto's and Graves. And I mean
Yeah.
PCOS if we went deeper, but it does affect our fertility. And I think that's a question, Cassie, that people really, women need to ask their providers if they're not conceiving. As we know, and probably with you, it took me 4 years to get diagnosed because my TSH was in normal range. It wasn't
Mm-hmm.
until so I'll give the nod to the endocrinologist on this one. He palpated my thyroid. He said I had an impressive thyroid. I said, thank you, thinking it was like pretty. And I thought, well, she can show up to weddings, bar mitzvahs. What do you need? And he was like, no, it's sizable. And that was the doctor that did look at my antibodies. So though my TSH crept up from 1.5, 2.5, I was at 3.8 finally, but my antibodies were
Mm-hmm.
1300. And I was starting vitiligo at the same time. So,
Yeah.
and that was they were like, okay, let's pull the trigger. This is Hashimoto's. But I'm telling you, it wasn't, I had to stomp my stiletto foot to say,
Mm-hmm.
listen to me. When I say I'm tired, I mean it.
Yeah.
And it was an endocrinologist who did take the further step. I guess maybe because you already had Graves, they were already looking at antibodies. But as you know, most providers don't look at antibodies, T3, reverse T3, and all the things.
Yeah. Well, actually, even though I had Graves, nobody looked at my antibodies until I did it myself. So,
There
yeah,
you go.
nobody did it for me either, even though I had Graves. And so, and I think you bring up a good point about fertility. I think a lot of the issue though with Hashimoto's, right? It's autoimmune. You have a lot of inflammation. So
Yes.
whatever's driving that inflammation, a lot of times you have high insulin levels and high
Yeah.
cortisol levels, and
Yeah.
all those things are debilitating to your gonads, all of them. And so it
Yeah.
causes issues with fertility. Yeah.
Yeah. My doctor, in fact, so this was 1999. My last baby came at 1998. After each baby, I kind of had an autoimmune blow up, right? I either had urticaria or I have a rare swallowing disorder. I mean, like each baby kind of spawned this. So, I was tapping my fingers saying something's wrong, something's wrong. And finally, when I did get the diagnosis, again, 4 years, I did have a provider who put me on Tapazole then,
Mm-hmm.
which is that the same drug you were taking for
Methimazole.
Graves? So
Methimazole.
and I remember because I was like an OG of the internet. This was 2002, 2003. I was like, why are you giving me Tapazole? He said, and he was 65 at the time. He said, it's kind of like what we used to do because we're trying to calm the storms. But I was
Mm-hmm.
like, but my antibodies are for this one and not this one. Would you ever do that? Would you ever give Tapazole for a Hashimoto's patient?
You can have toxic Hashimoto's, so it's not
Okay.
very common, but you
Yeah.
can. So it would depend on their TSH,
Yeah.
T3, T4. So if your if your T3 and T4 were high, then
Yeah.
maybe. But
Yeah. And so that was, again, I was an early adopter. I would read, my husband said, I would read thyroid books like they were murder mysteries. I turn the page and go, oh my gosh, because it all made sense. I was like, I'm living this,
Mhm.
the heavy periods, the hair loss, the loss of obviously pigmentation, but eyelashes even and eyebrow. I mean, all
Mhm.
these things that nobody put together because because I was about 40, I'm 60 now, I can't do math, but something like that. But when you're a woman who's 40 and you go in and say, well, I'm bleeding a lot, they'll go, great, we'll just do an ablation. And I went,
Mhm.
no, we're not doing that. Or if you say I have this, they had a pill, but nobody would find out, but why? What happened? So I
Right.
guess I just kind of want to lock arms with other women and just remind them, keep going back. Cause I was the first person to ask this doctor who was 65 at the time. I said, what about giving me armor? He said, girl, we hadn't heard about armor in years. He had been practicing, for 30 years at that point, 35 maybe. He said, that's an old timey drug that was grandfathered in by the FDA. He said, we're supposed to give you Synthroid. And I went, well, who sponsors the symposium at medical school? He said, Abbott Laboratories, what do they make? Synthroid. So
Right.
I was like early in the game in 2003 because I read Rita Aram's book. Is that his name? The endocrinologist from Houston wrote Thyroid Solution. Maybe there was like Thyroid Power, Thyroid Solution. There were a few books in the early 2000s. And I said, or give me some Cytomel. And that I finally got my life back doing the complete thyroid hormone replacement. Did you start with Synthroid first? Or
Yes.
it's awful.
Synthroid, yeah. Yeah, and to your point too, Dr. Broda Barnes, so he was an
Yeah, Broda
endocrinologist in the
Barnes. That's
50s.
yes, yes.
He was talking about this in the 50s, right? He was talking about desiccated thyroid in the 50s. And
He
I mean,
was.
in the 50s, 60s, 70s, he published data. Yeah, he did a very in-depth analysis of people where he knew that T3 was important. And so we've been talking about this for a long time, but to your point, my society, we haven't changed our guidelines despite the fact that we publish data all the time that shows T3 is important and shows that people feel better on it. There was a study that showed that 78% of people, if you blind them, they prefer T3 over T4. And we know that and we say that, but we don't change our guidelines. And so it's frustrating. Yeah.
I went to a university. We had University of Arkansas Medical Sciences here, and finally, when my antibodies got to 2,400, I had a sweet endocrinologist finally, and he said, "I'm just going to send you over to the med center because I want to see what's going on." And I was taking desiccated thyroid hormone, and they wouldn't refill it. I go, I'm the customer, and I thought the customer is always right. He said, this was in, like, I remember dates, 2008. He said, well, the National Institutes of Health hasn't done any funded research on it. And I went, well, I'm a study of one. It's helped me. And he said, I'm sorry, I can't refill your armor. I do NP now. And I was like, nice to meet you. I'm not. He said, when you come back in 6 months, I went, oh no, we're done.
Yeah.
We're breaking up as of this point.
Yeah, and it's really frustrating because in medical school, I want to blame doctors, but at the same time, I don't want to blame doctors because they
Right.
teach us in medical school. Here's what you learn in medical school. Go see that patient, go make sure that patient's ready to go home. Let's get rid of them. Like their labs look
Right.
good. They're in
Right.
the box. Goodbye. It's not like, hey, how are you feeling? How are you? Like they don't teach us that in medical school. They teach you it's very, here's the box. They fit in the box. It's fine. And so it's just a very discombobulated way to teach medicine, unfortunately, and to practice medicine. Because I'll tell you, if you do that, your patients don't feel better. They don't come back and they
Oh
don't
no.
like you. And so, I know this seems crazy, but medicine is, you got to ask people how they feel. And then you have to use your judgment and what you know to make decisions to help them feel better. And you have to also use physiology and, just what we teach people in medicine right now is very outdated. And we have a ton of research that shows that it's outdated. And we publish this research, just nobody reads it or nobody does anything about it.
Nobody reads it. Well,
It's
great.
like nobody reads it, or if they do read it, they read it, but they still don't change anything. I don't know. It's crazy, but there's so much research now that talks about T3 and how T3 is so important at a cellular level and how it doesn't correlate with TSH and it doesn't correlate with free
No.
T4 and it doesn't correlate with how you feel.
No.
But yet my society's guidelines, the endocrine society's guidelines still say you use TSH to diagnose. You don't treat Hashimoto's unless their TSH is high. Like, something's going on, but you don't do anything.
That is
It's
hateful
crazy.
to women. I mean,
It's
I
hateful.
hate to be that way, but unless that man has walked in my shoes, they don't get it. This is where I think also that happens. In the South, you ask a woman how she is. What does she say? Fine, thank you.
Fine.
Whereas I tell my clients, go in there and bitch and moan. When they say, how are you? Go, my life sucks. I hate my family 1 week of the month. I'm constipated. I'm cold. My hair falls out. How do you think I'm feeling? Do not go in there and say I'm fine. So gripe. But the first endocrinologist I went to, when I went back for my follow-up 4 weeks after he palpated and said it was impressive goiter. Thank you. My TSH went from 3.8 down to 1. And he said, oh no, I was on 75 micrograms of Synthroid, and that's kind of titrated by weight, and I weigh about 150. I was like, at 75, I'm not good at math, but that's not the same as 150. That's about half. He said, oh, we think that 1 is a good number for TSH. And I go, wait, I didn't know who he was talking about. I didn't know it was a society of mean people, the endocrine society. And I said, who's we? And he goes, well, the National Academy of the Endocrinology or whatever. And I said, if you lived with me, you would not think 1's a good number. I go, 1's not my target because this isn't working. And so I broke up with that one too. I'm the one like Elaine Bennis on Seinfeld where it says difficult patient. And on every chart at every doctor's office in Little Rock, Arkansas, until I found a provider who writes the amount of NP that I need. And because of that, I've titrated it. I only take it 4 days a week. And then I'm trying to wean off because I brought my antibodies down, trying to wean off that. So you just have to be your own advocate, and women listening, and a few men who get it, this many men get it. Fight for yourself. Your husband will thank you. Your kids will thank you.
Yeah. I mean, it's hard, but yes, you know your body the best. And so
better than a lab value.
You just have to find a provider that understands it and understands physiology, right? But I tell people this all the time when doctors will ask me or patients will ask me, well, aren't you scared if I have a patient who takes 800 micrograms of Tirosint a day. 800.
Now, is she thyroid hormone resistant then?
She has a lot of issues. She had gastric bypass, so I think she has issues absorbing it. She has but I mean, yeah, and she actually even takes some IV thyroid medication because but yes, 800 a day. But I mean, that's what it takes. And whenever I've talked to some different endocrinologists about her, they're like, "Are you trying to kill her?" I'm like, no, I'm not trying to feel better. I'm trying to make her be able to function, So everyone's different. I mean, you have to get outside of that box. You have to give people, and her TSH is not, I mean, it's not super low. Everyone's different. I mean, that's the thing about medicine, right? Like everyone's body is different. You're going through, I mean, my body is different today than it was 3 months ago. It's going to be different than it is in 3. I mean, it's your body. It's such a complex, system of cells and organs. You have to look at everything that's going on. How stressed are you? What is your insulin level? Are you on your menstrual cycle? Are you sleeping? What are you eating? I mean, so there's so many different things. And so, yes, you're going to know your body better than anyone else, right?
I guess it's insulting for us as patients when they think they know our body better than we do. And when he said, well, we think 1 is a good number for TSH. If you looked at my TSH now, it's so suppressed because of what the NP does, the desiccated thyroid, it will often suppress your TSH. But I have a provider now who's like, let's not look at that. But she asked me, what's your blood pressure doing? Well, it's 100/70. What's your weight? It's good. It's just a lot of variables. So I just want women listening, especially, to really fight for themselves. If you think something is wrong, go back and find a provider you can communicate with.
Well, and we also know that TSH, so Jeff Garber, the guy who writes the Endocrine Society guidelines, he wrote a paper and published a paper that said that TSH is not a good function of actual thyroid, hormone. So the guy who writes the guidelines also said TSH is not useful and there's a whole list of things, when you're inflamed at certain times of the day. So, I mean, the Endocrine Society knows that TSH is not the end all be all. It's not, you can't pin everything on TSH. So even though your TSH is low, if your T3 and T4 are where they need to be, your free levels, that's perfect. So your TSH probably just isn't working, right? So that's it. And so it's crazy. There's all this published data that says that. And so, like you said, you just have to be an advocate of your, of your own health. And then I will say for doctors though too, doctors, I think a lot of times get scared, right? Because they learn in school that if you suppress someone's TSH, you can give them AFib or you can give them, but not all that is true. That is not true. There's data that shows that. And then, unfortunately we have people that, sue doctors and they're all these. So I think
I understand.
There's a lot of people that are just, fearful, but if you really understand physiology, right? So if you understand how the thyroid works, you understand hormones, you understand that if I give you too much hormone, you're going to be in my office because you're going to be having tremors and you're going to have diarrhea and you're going to be tachycardia. I mean, you're going to know these things.
It's being over replaced is almost worse than being under replaced. Because I've done that too. Yeah, I've done that. I was taking Cytomel like candy one time because I was the guinea pig for a doctor. The same doctor who was 65 when he was seeing me He's the one that told me that the TSH, thyroid stimulating hormone test, was introduced by Abbott Laboratories in 1973. The same people who make Synthroid. Isn't that amazing? And that they were told, because, he'd been practicing all this time, that you don't even talk to patients anymore. All you do is give a blood test. That's when the reference range was 10 point. I mean, I would be dead if mine even gets to 2. I'm not doing well. He said, and then that was 1973. So they said, guess what? You don't even have to talk to patients anymore. Because before that, they did the reflex test. Remember if their reflexes were slow. And so my reflexes were real slow that day. So I thought I had reflex cancer because that's where my brain goes, not knowing that there isn't a thing called reflex cancer. But that, I've read Good Housekeeping and I'm sure Journal, and I'm sure there was an article about a woman who had something like that. So He said that was 1973. And he said then in 1980, the endocrinologist, somebody got together and said, we have all these people now that they don't have thyroid disease according to the test. So they said, let's give that a new name. Let's call it, what do you want to call it? Fibromyalgia. He said that name was invented in 1980 he said it was kind of a net to catch the people who weren't then being diagnosed with Hashimoto or low thyroid. We'll say hypothyroidism. So you have to, the old timey version was they talked to the patient, palpated her thyroid. And he said, if it looked like a duck, act like a duck, quack like a duck, it was a duck.
Yeah. And they use their brains. They used to use their brains when they were doctors. Right. And now I think we just are so burdened with let's see 50 people a day. Let's put you in a box and move you out. I mean, they don't teach you in med school I remember when I was in med school, I had one teacher. He was a cardiologist. He was an older gentleman, a wonderful teacher, literally was in his 80s. And you would learn so much from him. People would get frustrated because, he would spend an hour in a patient's room talking to them and lay them down and look at their, look at their, he wanted to show you their JVD and show you all these things. And and he would tell you, I can tell by listening to them, they have this murmur, they have this. And I used to think wow. And what he told me one time, he said, Cassie, whenever I was in med school, we didn't have all these fancy things you guys have. We didn't have echoes. We didn't have, he was like, you had to talk to the patient and put the puzzle pieces together. Right. And I remember thinking wow, he's the probably one of the only providers I ever was in training with that did that. Everyone else was
an internist or an endocrinologist?
He was a cardiologist.
Wow. Because internists are kind of puzzle pieces to me, people who start, diagnosing, but a cardiologist act that way. He was
a cardiologist, and he was
so beautiful.
And it was fascinating, right? And I remember we would listen. I remember I was in a room with him, and he was like, "Listen to this," and he told me what to listen to, and he was like, "I bet this person has aortic stenosis," and I was like, "How does he know?" Murmurs. Yes, they have a certain murmur, but how they definitely have. I remember he told me they definitely have aortic stenosis, and it's probably 50 to 70%. And I'm like, how do you know that? And he's like, and then they got an echo and they did.
And I
was like, that is so crazy.
That really gives me chills. I love that kind of medicine. That's
how it used to be. Yeah. I don't think that's how it is anymore. And there's a lot of things that need to change with med schools, pharmaceutical companies, a lot of things. But we got it. I mean, you have to teach people in med school that although medicine is kind of yes, you need to figure out. I mean, I think they teach people just enough to be a little bit dangerous. But if you don't mix what you know with how somebody feels and physiology and put it all together, I mean, it's it's not going to work, right?
Yeah,
I mean,
exactly.
There has to be some thought process there.
Well, with your love of the beloved thyroid, which is the gas pedal to the body, which it changed my life. That diagnosis changed my life, changed the trajectory of my career. I've been in radio, TV all this time, but I've always had a passion of helping women. What is your passion, though? I mean, a lot about the thyroid. It really helps a woman tick. But right now, what are you seeing? Is it bioidentical hormone replacement therapy? What is it?
Yeah, so I actually still do the full gamut of endocrinology, although I'm trying to kind of get it a little more narrowed because I can't keep doing that. And so honestly, diabetes used to be my passion, but it's not anymore. It's since I've gone through this, so thyroid disease and then hormones, insulin resistance, those things right now, I mean, and they all go hand in hand, right? But I really love hormones as well. Love hormones. I've seen it change so many people's lives, and there's so much bad misinformation about hormones. So that's really where my passion lies right now. And not only with patients, but I'm really trying to help providers understand all the disconnects with hormones because, as much as I would love to treat 300 million people in this country, I know I can't, right? And so
Right.
the thing
I
that I
understand.
can do is I can help as many people as I can, but I can help teach doctors to go help other people,
Good.
right? So that's where my passion lies, in like, let me help you understand the things they didn't teach you in medical school. Let me
Good.
help you understand, physiology. Let me help you understand not only what data has shown and studies have shown, but I've been doing this for 3 years now. And I mean, let me help you understand this so that you can help people, because unless we start doing this correctly, I mean, we're in trouble. Our country's already in trouble, right? Like,
Yeah.
70% of us are either obese or overweight, 70%. 1 in 3 people are going to have diabetes in the next 10 years.
Oh,
We're
it'll be
spending
more than that. Yeah.
trillions of dollars on healthcare. I mean, it's just, it's so sad. And it's like, I say this, but I mean, it's kind of crappy, but I read something the other day. I mean, American hospitals were made for people to be sick and be in these
That's right.
hospitals. Like, this medicine in this country is built on you being sick and spending your money on things that keep you sick and keep you in American hospitals and keep you taking American drugs. And it's not why I went into medicine. It's kind of my belief around that has changed a lot over the last few years. And I mean, you as the patient have the choice. Like, you have the choice to get the right knowledge, to make the right decisions, and to help fix yourself. And so you just need good information. And what kills me is all that negative, bad information out there. What we need to be doing as doctors is sharing the correct information, the most up-to-date information, the stuff that makes people feel better. And I'm not saying everyone, like, before I get all the hate, I'm not saying every single person needs bioidentical hormones. I mean,
Yeah.
it's your body, you do
Absolutely.
you do, but I
Your
mean,
choice.
it's
Yeah.
your choice. You get to live with your choices and your consequences and your
That's right.
decisions in this country. That's the great thing about America. You can make your own choices and you can live with those choices. But
Yeah.
I think that people need to realize there's really good data out there, and they need to understand all the data around bioidentical hormones and around lowering insulin and around fixing your thyroid so that you can, live and be the best you. Because if you look, the last 20 years, we're not getting better in this country. We're getting worse.
No,
We're
we're,
fatter.
it's
We
sicker.
have more, yeah, we're
Yeah.
fatter, we're sicker, and so there's something wrong, right? When everything
Yeah.
else in the world is getting better, like
Yeah.
technology is better, we're living longer, but we are not healthier. And
Yeah.
so people need to start asking why. They need to start making good decisions, educated decisions, and they need to, I mean, you have the power as the patient. Like, you get to make the choice. You just have to figure out the right choices to make. And it's scary, and you need, somebody who understands those things. But you're right, you have to be your own advocate, and you have to make good choices. And so I love helping those people. I love it when people come to me and they just say, I don't know, I'm a mess, test everything and help me feel better. Okay, well, I mean, let's do it. And then I love when I do teaching once a month for physicians in Dallas. And I love
Good.
it when there are people there and they're asking questions and they're engaged. And it's a lot of work. It's a lot of time commitment. I'm away from my family. I mean, but if I tell myself every day when I go there and I'm there for 5 or 6 hours, if just one physician leaves here and buys into this and goes and helps people, it's worth the weekend that I spent here, right?
I
Because
absolutely agree.
and
Well,
so,
I'm glad there are physicians who are wanting to think outside the box and to see what this pretty girl from Oklahoma City has to teach them, and that it could change not just their practice, but the trajectory of the patient's health,
right.
and not being customers of Big Pharma the rest of our lives. You can age. My aunt will be 99 next week.
Wow.
Finally had to put her in a facility because she's demented now. No medicine, not blood pressure, nothing. I mean, she had no provider. Do you know how hard it is to get admitted to a nursing home when you don't have a
When you don't have a
provider?
doctor.
They've never had that. In fact, Medicare dropped her benefits because they thought she was dead, because she had never used a doctor. Because you know what she did? She did yoga every day. She went on
Mm-hmm.
a walk every day, and finally tripped over her dog at 98,
Mm,
broke her hip. But girl, that was 15 months ago. They said that they gave her 4 weeks in. Well, here we are celebrating 99 years. But my point is, she lived in Europe a long time, came back to the US, and just had the mindset of, oh, no, let me take care of this.
mm-hmm.
And because of that, she clearly not a customer of Big Pharma. So I just like people, that's it. Be informed, make the decision, but don't make it based on one opinion that's sponsored by Big Pharma and Big Food. I mean,
And
that's it.
don't make it based on fear either. Like get
Oh
good
no. Yeah.
knowledge, right? Like
Right.
get if you know, like I have people who come at me like, yes, this definitely causes cancer. Well, Google, does estrogen cause cancer? And look at
I'm
the
so tired of that.
extensive
Yes. I'm
data.
so
You know what I
tired
mean?
of
Like
that one.
so
Yeah.
and because I can give you like, and I understand how to read medical literature, but I mean, even somebody with a high school, anyone with a high school diploma, you can
Yeah.
get on Google now and you can
Right.
find all sorts of things and read it, you know, or you can get on YouTube, or you can get on, and I mean, you can look at my credentials, you can look where they came from, you can, I mean, you know, it's just, you have the ability to learn, right? Just like I did, just like you did. Whenever I
Yeah.
didn't feel good, I was like, you know what? I'm going to learn everything I can about this, and then I'm going to make a decision. And yes, there's always going to be pluses and minuses, but you get to make that decision and you get to determine, you know, and I tell people, maybe try it, see what happens. You know, worst case scenario, you can't feel worse than you already do, right? So why don't you give this treatment a try and see what happens?
Oh,
Like, you know,
it will
it's,
make you feel better for sure. I mean, you
yeah.
get your life back. I kind of wish I'd started um, estrogen replacement earlier. I did start progesterone in my 40s when I had the 2 a.m. wake up. And so, but
Mm-hmm.
I wish I'd done the full Monty then, but I don't think I had all the information I do now. The one thing I'm loving about this dementia research is now we're seeing that estrogen is cardioprotective and could be a dementia preventative. Talk about that just a minute.
Yeah, so estrogen, but also testosterone. So testosterone
Oh,
is
good. I do both.
hugely dementia. So
Because my
if your
testosterone.
if your testosterone is low, you're 7 to 8 times more likely to develop dementia as a woman. And that it
Wow.
makes sense, right? So if you go into a nursing home, what do you see? You see a bunch of women, right?
Uh-huh.
So that's because women have a lot lower testosterone levels
Uh-huh.
than men. And so dementia is something that's kind of near and dear to my heart and gets me fired up too, because let's talk about what we offer people in this country with dementia. Big Pharma offers them terrible medication that costs $100,000 a month, and none of it does anything to fix their dementia. None
No,
of it is
no,
disease modifying. None of it.
no.
It does not modify the disease. It might help the symptoms, but it doesn't do anything for these people. And it
And
costs
wasn't
as
the
much as a
research on
house.
that, wasn't that based on erroneous or lies that like
It,
the it was Aricept or one of the drugs, it didn't help.
oh,
It was based on erroneous information. It
right.
makes me nutty.
The most recent one that came out, you know, that was FDA approved within the last couple of years, basically when they brought all the people in and looked at it, all the, you know, the people who they were like, okay, you're experts in the field of this. They all said, they told the FDA, like, this drug doesn't really do anything that the other ones don't, but it was still released and the FDA still approved it. And when you get down to why, it was because the FDA was like, well, we hadn't had anything new for these people in a while, and we needed to not give them false hope, and we want them, but it doesn't, you know, they're SARMs and monoclonal antibodies, and we don't have
Mm-hmm.
receptors for monoclonal antibodies in our head. Like that's not, you know what we do have receptors
Uh,
for in our head though? We have receptors for testosterone and
uh,
estrogen and omega
wow.
and vitamin D and T3. These are all the things that you have receptors
Wow.
for in your brain, right? So for me, somebody who's thinking like, because my grandma had dementia, she died of dementia. I have dementia that runs in my family. I take care of a ton of people with dementia. So if you're asking me as a doctor, like, okay, I know all these medicines that are really expensive definitely don't change your course. And I know you don't have antibodies in your or receptors in your brain for these. So what could you do? Well, what you need to do is figure out what receptors you have in your brain and how you fix those, right? So you have T3 receptors. We're
Mm-hmm.
talking about T3.
Mm-hmm.
You have estrogen, you
Mm-hmm.
have testosterone, you have vitamin D. So you want to make sure your vitamin D is good. You have omega receptors. And so
Mm-hmm.
there's a company called Plasminogen. I don't know if you've
Yeah.
have heard of
Yeah.
this.
Mm-hmm.
Yeah, so I take those supplements every day. You can do a blood test to see if you're deficient. But I mean, these are the things that you do to you know, and then you exercise, so blood flow to your brain, right? So that's
Yeah.
another huge thing. So you exercise, and but you don't take these $100,000 drugs that don't do anything. And so the frustrating thing for me too about big pharma is like, they're not doing any research on any of that. Nobody talks about any of this. All they're doing research on are these monoclonal antibodies that cost as much as a house.
Right.
They're not talking about, hey, let's take some vitamin D, let's go for a walk, let's exercise.
Because they're not going to make any money.
And so that's what's frustrating to me, right? If you want to talk about dementia, it's let's get your hormones fixed. Let's get your thyroid fixed.
Right. Oh, yeah.
That's going to help a ton.
Really fascinating. Max Lugavere last year when he was on Joe Rogan, that was a 3-hour conversation because Max Lugavere got into the health space because of his own mother's dementia. And then because, for years we'd hear, well, my grandmother had it or my mother had it. And Mark Hyman is famous for saying genetics loads the gun, but lifestyle pulls the trigger. And so it's Max Lugavere said the APOE4 gene, it was like less than 1% of the population, or maybe 1% of the population. He said those are the only ones that truly he felt like had a genetic predisposition. The rest were environmental. The vitamin D, like you said, vitamin D. Okay. You know what? It's free to sit outside every day and get sunlight for 20 minutes, no sunscreen. Vitamin D goes up. It's the low price of free. And the other, obviously.
Exercise is the best medicine you can take, and it's free. Increases blood flow. It helps with endorphins. It increases your dopamine, makes cytokines from your muscle go to your brain. I mean, exercise is free. And even if that's to take a walk, if that's to, I tell patients, we live in Oklahoma. It's too hot. Okay, walk around your coffee table. I don't care. Walk 100 times around your coffee table. Do jumping jacks. I mean, it's free. You're right. Like it's, and then the other thing is, we do all these things that decrease flow to our brain, right? So alcohol and not sleeping enough and not exercising. But I mean, it's crazy. It's all about choices. It's crazy. And
I'm a 7-year intermittent faster. So that obviously we've seen there is research about fasting and autophagy and other things. Dr. Thomas Seyfried has been making the rounds recently. He's the PhD researcher from Boston College who talks about the metabolic mitochondrial approach to cancer treatment. It's absolutely fascinating. And he's kind of a nutty professor, he kind of laughs at his own jokes, and he's this brilliant PhD. But, when he talks about treating cancer without the use of big pharma, I think, oh, there's a target on his back. But the way he answers it, because my husband was yelling at him in the car when we were listening to him on Mark Hyman the other day, because Mark Hyman said, well, Dr. Seyfried, why do you think people have, why do you think doctors still prescribe chemo and radiation? He said, it's dogma. It's dogma. My husband was yelling at, the radio where you're listening to it in your car going, it's money. And I thought, you know what? There's already one target on his back. He doesn't want to piss off big pharma because, you get sideways with some of those people. You wake up dead one day, mysteriously. I hate to be so cynical, but look, I've lived during the Clinton presidency. I'm from Arkansas. I'm suspicious of every death now. But I noticed the way he answered it was so that he could see his 78th birthday and go, yeah, it's just dogma. Because you're really like, really? You got to be thinking it's more than that. But
some of it may just be that some doctors are misinformed too, right? Or that's what they believe. I mean, I don't know.
You seen that science though about the metabolic mitochondrial approach to cancer treatment? I have. Vitamin C therapy and other. It is.
I do a lot of it. Yeah, I do some of that in my clinic now. We do high dose vitamin C. We do NAD. We do glutathione.
Yeah.
And then all of the oxygen therapy, the oxygen baths, the fasting. I think it's all fascinating, and then, here's the other thing, like we discussed, there's more than one way to skin a cat, right? You get to make a choice in this country.
That's right.
And so if you have cancer, then maybe find an oncologist that has different approaches. And I know that might be difficult to do, but
good luck.
Yeah. I mean,
I saw where there's, because I had a guy named Cancer Fighter Owen on my podcast, and he has stage 4 recurrence of thymus cancer. At stage 2, they practically brought him to the brink of death. And so when it recurred at stage 4, he said famous words that many cancer patients with metastasized cancer say, never again. So he said the hard part is finding a provider because you have to have one. You can't just go to your provider and go, just hit me up with the vitamin C and the glutathione.
Mm-hmm.
They'll say, well, there's the door. And it was nice
Mm-hmm.
knowing you. So he did have, I remember, if anyone listening, you can go back and look for that episode, Cancer Fighter Owen, Lisa Fisher said. And there was something called a functional oncologist,
Oh.
which is pretty bold of an oncologist to want to look at the
Mm-hmm.
root cause.
Right.
But you do have to dig deep. So I'm glad to know we can put your name in the hat, at least for somebody who's open, and they can make an appointment with you, I'm sure, on your website.
Yeah. And, for your point, though, you said what's sad is like this functional oncologist, as a doctor, at least this is how I feel about it, right? So I went to school, I have training, but my job is never to dictate your care, ever. My job is to give you information, listen to your
Yes.
information, and then to
Yes.
help you, however that needs to happen in that journey, right? So the fact that oncologists would, try to make someone feel bad about their decision is also kind of sad and frustrating, because that's not,
Oh,
I didn't go to school to be Jesus, right? I didn't go to school to
right.
dictate you and to tell you what to do. I went to school to learn and then be able to help you the best I can through your journey of life, whatever that is, right? Because people make decisions all day long that make me mad, right? I have diabetics that don't take their medicine, that don't eat right,
Right.
I'm not angry at them. I'm not pissed off. I'm not, I'm here to help
Right.
you meet you where you are, do the best you can. And it should be the same no matter what in medicine. I mean, if you went into medicine to boss people around and have a God complex and an ego complex, then
Have you met
I don't
any
know. Like,
oncologists?
well, I mean, and that's just kind of sad though. That's not how it should be, right? And so that's how
Yeah.
I look at it. Like, I mean, you can make whatever decision you want. It might not be the decision that I would make, but
Right.
still, as your provider, I need to respect that, help you all that I can, and you just document that. Like, yes, I would be happy to give you high dose vitamin C and NAD and glutathione and whatever you want to take if you decide that you do not want to take chemotherapy. Like, that's your choice,
No,
that's your choice.
no,
And
I agree. But
that's,
I'm telling you, the other
yeah,
perspective happens,
unfortunately.
because I have a client right
Correct.
now who's my fasting client. She's lost 70 pounds or whatever. And they think she has a recurrence, stage 4. They ripped off her breasts, took out her ovaries, took out her gallbladder, like they do women who are fat, 40 and fair. She gained 90 pounds. Well, I mean, you see it all the
Yeah.
time. And so
Yeah.
she went to the oncologist and said, I brought the book. I'm considering this. And they literally said, that's the door. No one here at this facility will treat you. She said, you won't even prescribe vitamin C. And they went, they go, vitamin C, really? So
That's really sad. And this thing is too, there's a lot of data that shows if you've had hormone cancer, I mean, you can still take hormones even though you've had breast cancer. There's
I,
great data that shows that, and you
I sent
actually
her
do
with
better.
that. I sent her with
Yeah.
that. And they also said, that's wrong too. So
Yeah.
you see, not that I don't even think they said it was wrong. They said, we will not treat you, and we won't see you. We won't advise you. We're
Yeah.
done. Dunzers here.
And that's really sad, right? Because I mean,
It's
again,
it's bullying.
yeah, it is. It's not,
It's
I mean, I guess I also have the mentality of like what I always try to remember, because I see a lot of patients that can have hormonal swings, and I mean, they're not always feeling well, right? I try to always remember every time I talk to somebody, like, is this how I would want somebody to treat my grandma, father,
that's
sister,
sweet.
mother?
Yeah.
Like,
Good.
and you just need to have that mentality as a doctor. Like, you don't need to, I mean, and you just need to document it. I understand, like, yes, they might be concerned from a medical legal standpoint, but if you've got a person standing there saying, I'm not doing this, I'm miserable, I'm
She
not
said, I'm
taking
not
your
doing it.
drugs,
Right.
I'm not, but I'm miserable and I have all these symptoms, and what can you do to make me feel better? Well, you have an arsenal of things that can make you feel better. It might not be the best thing that they can take, right? But I mean, again, we all make choices. People don't make the best food choices every day. People don't make the best sleep
Right.
choices every day. I mean, you're still, as a doctor, I mean, obliged to help them do the best that they can with what they're asking, I guess. So that's where that's where it kind of infuriates me, right? Like,
When you come to Little Rock and start teaching the oncologist here, I will be the person who introduces you. I'll have you over for lunch, because I'm a lot of fun. Another thing you talk about is methylation. So we know a lot of us have the MTHFR. Is that a gene? What is that?
Yep. It's a gene mutation.
Gene mutation. And so that means we don't methylate B vitamins. Am I saying that right?
Yep, you don't methylate B vitamins. So you can't make activated folate, basically. So your tetrahydrofolate is not activated. And so there's a gene that helps your body kind of turn on your B vitamins, I guess
Okay.
you would say, turn them on. So you get them, but then you have to activate them or turn them on in order for them to work. And so 60% of North Americans, it's estimated, can't do that for whatever reason,
Okay.
whether
All
it
right.
be genetic or they're inflamed. I think a lot of it goes back to inflammation, right? So
Yeah.
when your thyroid's not working, your cortisol's high,
Yeah.
you get those B vitamins, but it's like they're there, but they're not activated. Like they can't do anything. Like they just run into the receptor. They have to be turned on in order for your body to actually take them, pull them in and use them. And so that genetic mutation that people have, that MTHFR, if you don't give them the methylated B vitamins, then it doesn't work. And so there's tons of people that take B vitamins, but they're not methylated and they
Okay.
have issues with MTHFR, and it causes a lot of downregulation issues. So the most common thing I see is anxiety and depression. It actually messes with your
Wow.
neurotransmitters. So dopamine, serotonin, a lot. And so I think a lot of these people that have anxiety and depression, a lot of them have methylation issues.
So should we assume they do and treat them with methylated B vitamins?
Well, you could, or you can do a simple blood test and check a B12 and a folate level. And if
Okay.
their B12 and folate levels, are off, that's one way to look at it. You can look at homocysteine levels. But I would say, me personally, when somebody comes to me and they say, I'm having a really hard time, I'm super anxious, I'm super depressed, instead of throwing an SSRI at them or trazodone or something, what
Yeah.
we all do, how difficult is it to say, hey, why don't you try this methylated B vitamin? Worst case scenario, you get too much B vitamins and you pee them out. Best case
All right.
scenario, you start metabolizing your carbohydrates better, you help your fat storage, you help your neurotransmitters, you help your energy, you help your brain. I don't really see a downfall in this, right? If you give someone an SSRI, they could become more, it can make their depression worse, it can make them gain weight, so
Suicidal.
to me,
Yeah.
it doesn't make sense. Like, why aren't we starting with these things that are maybe a little bit easier, right? And so I tell people this, and they look at me like I'm crazy. And I have a lot of people who come to me and they're already on all these medicines and they're having severe anxiety and depression. And I'm like, we need to get you on a methylated B vitamin. We need to make sure your thyroid's good, and then let's look at your hormones. And then when they're feeling better, I'm like, okay, let's start getting you off some of these
Mhm.
SSRIs, and let's start, because I think there are millions of people that see doctors and say these things, and they just, that's what we do. Oh, here's fluoxetine, here's Prozac, here's,
Mm,
that's not, the question is why? Like, why is there
right.
dopamine and like, what's the deal? Is it their gut? Is it their B vitamins? And so I think there's a ton of people that struggle with that. And it has to do with, it helps a lot with weight as well. So as you're losing weight, your B vitamin requirements go up. And so some people that are losing weight and then kind of stall out and feel really tired, I think a lot of it sometimes is they have methylation issues because they need more B vitamins. So it
And then
affects a
this,
lot of things.
yeah, for sure. Because we've been hearing about it, even conception, um, carrying the baby,
Mm-hmm.
maintaining the pregnancy. I know that people with
Mm-hmm.
MTHFR have trouble with that. Also, it reminds me of the whole SSRI conversation. That at the same time we heard that bullshit. They lied on the testing for dementia or all that research on dementia. They also that low serotonin was not the cause of depression. Because remember, for the last 30 years, we've been saying I must have low serotonin. Well,
Mm-hmm.
no, and Chris Palmer in his book, who also, if we talk about mitochondrial metabolic root
Metabolism.
cause, he talks all about it with mental health, and that his book is fascinating. Brain injury, energy. Everybody, if you have anyone in your family or with any depression, anxiety, suicide ideation, they need to read that book. Have you read? Are you familiar with his research?
I haven't read his, no.
It's fascinating.
I'm familiar with research like that, but
Yeah,
what's the book called?
his is Brain Energy. He's the Harvard
Brain Energy.
psychiatrist who started noticing that people, and he himself lost 130 pounds doing keto diet.
Mm-hmm.
We know keto diet is beneficial for epilepsy. And so he started looking at it deeper and deeper. And so he's an MD. He's at Harvard. His patients have gotten off medicines for schizophrenia, schizoaffective disorder, bipolar disorder, the things that doctors say, oh, you're on medicine the rest of your life. He says, no, you're not.
Right.
He goes, change your, the metabolic and mitochondrial approach and watch what happens.
Yeah, well, I think a lot of ADHD kids that are diagnosed with ADHD and adults now too. I mean, there's a lot of research that shows you can help reverse that or get them off of medications with certain
he says
diets.
That too.
And
yes.
Yeah, and that's the other thing we were talking about dementia. The other receptors that you have in your brain are glucose. So your brain needs glucose as well. So yes, this ketogenic diet can help with that. But all that research is very fascinating. I am familiar with the mitochondrial research and the anti-aging, but I will definitely read that book. That sounds.
But again, the dependence on that, Cassie, means less dependence on big pharma. So you don't feel threatened by that, but the people who, Bristol Myers Squibb, or brought to you by, whoever, what makes the shots and everything. Those people are going, no, we want you to take our medicine. You'll be fine. Here, take 2. They're small.
Yeah. I mean, and there are going to be some people that need medicine, right? I'm not
saying
but I'm saying that, I think that doctors have gotten really prescription happy, unfortunately. And
well, not you, but most of them only have 10 minutes with the patient.
Oh, I mean, there are some days I do too, but again, you just have to go back to, again, the root cause, I guess, like what's causing all of this, right?
Yeah.
And my patients, I kind of joke with them, but I have a lady I started seeing a few years ago, and she was in her 80s and she was on like 10 medicine. And I'm like, why are you even on these medicines? And she's like, I don't know. And so I told her grandson, I was like, I'm going to get her off of all of her medicine if I can. And he's like, and so she just turned 90 and she doesn't take any medicine anymore. Like I've slowly and so it's just like, why? I don't know. I think that's what we learn, right? In med school, you learn, okay, what can you give them to shut them up and get them out of here? I mean, that's mean, but what can you do to get them
cut to the chase?
And it's like long term, I don't know that we're doing the best thing for them, right? I mean, maybe in certain circumstances, right? I think there are some drugs that do help, and maybe for a certain amount of time, but it's like, we really should be trying to figure out how do we fix this from the inside and not need to be on these medicines long term. I agree.
Well, you've totally changed my opinion now on endocrinologist. You and my original Dr. John Baldridge, who is 80 something, is in Northwest Arkansas, and I still call him for things, but you actually talk to the patient, and we patients thank you.
Well, thank you. I appreciate that.
Great job today. Great interview. I'm glad I tracked you down.
Yep.
So people will put all the information about you. Your social media is great. We'll put it in the show notes and send people your way. Thank you so much for doing this today, Dr. Smith.
Well, thank you for having me. It was nice to meet you.
Thanks for listening to the Lisa Fisher Said podcast. Be sure to hit subscribe and download all the episodes and leave a review, won't you? The Lisa Fisher Said podcast is produced by ClantonCreative.com.